The last letter in the word stupid is D, for defunct. The Encarta Dictionary defines defunct as follows. First definition, not operating now, no longer operative, valid, or functional. Now, stupid goals will neither support our services nor will they benefit our patients, so stupid goals are D for defunct as per this definition. But there's a second definition here. Dead, no longer alive or in existence. Now, our agencies will need to be smart to survive in our ever-progressing and changing healthcare environment. Stupid goals could write our agencies out of existence. So this definition of defunct is a perfect ending to our stupid goal examples.
To reinforce what a SMART goal is, we have another list here for your reference. Remember that your goals should be patient-centered, always. Impairments should be defined by tests and measures. Refer to some of the common tests and measures that we've included in the toolbox, which is provided with your course materials. Your goals should be concrete and predictive, working the patient toward desired functional outcomes. And your goals should always guide your interventions, always.
So we shall remove our hats. And this is a chance for you, the course participant, to be the judge. I will read a goal, and you get to decide if the goal is smart or stupid. We will use our captive audience member, Nancy, who may now join us to provide her insight as well. Okay, here is the first goal I will present for your consideration. It is to be achieved by our patient within a 3-week time frame. The goal is no falls. Now, since I'm a PT, no falls has long been my favorite goal to write. This goal is short and to the point. I use it for nearly all my patients. Sometimes my patients even succeed in not falling. What do you think of this goal, Nancy?
I hate to tell you, but I think it's stupid. This goal is not specific to an individual. It could be written for anyone. It does not suggest a skilled intervention or even hint at the use of a measure which would be used to indicate whether the patient is at lower risk for falls once we complete our interventions. I would call it a stupid goal.
Okay,
Sorry.
let's try another goal. In 3 weeks, the patient will have decreased fall risk. What do you think, Nance?
Well, it's not specific, it's not measurable, so it doesn't meet the S and M, the first 2 letters of SMART. A goal needs to be relevant toward the findings of our evaluation. Wouldn't it be better if we wrote something like, the patient will implement removal of throw rugs and clutter in walkways, and will install grab bars in the shower and the toilet to decrease his fall risk? I think that would improve the goal.
Okay, try this one. In 3 weeks, the patient will improve Tenetti gait and balance score from 20 to 25 out of 28. This one's measurable.
Well, we're getting much better. It is measurable, but it kind of reads like a chemistry experiment. You may be more relevant, or the goal may be more relevant to the patient with further clarification. For example, we could write, the patient will demonstrate an improved Tenetti gait and balance score by exhibiting good foot clearance and even step length during his gait, and demonstrating good control with sit to stand without even using arm support.
So here's another goal that I'm particularly fond of, Nancy. In 3 weeks, the patient will have better pain control.
Well, I guess that's what a lot of our patients want, so it could be a patient-centered goal.
You've taught me well. The problem with this goal is that it's not specific to an individual patient, nor is it measurable. It is too vague and subjective. How about if we used a pain scale to make it more specific and measurable?
Yeah, okay, here's a better shot at a better goal. In 3 weeks, the patient will consistently report pain managed at a 3 of 10 or less, with the ability to sleep for 6 hours each night.
Now that is great. It is specific and measurable. It could be both relevant and attainable for a patient with poor pain management who has an acute pain scenario and is not sleeping through the night.
Fair enough. The next set of goals, in 2 weeks, the patient will demonstrate independent transfers to and from his vehicle.
Well, that is specific and measurable. And it would be relevant and attainable for a patient who wants to return to driving after an acute and resolvable episode.
Okay, how about this goal? In 2 weeks, the patient will transfer with minimal assistance.
Transfer where? With whose assistance? And how? This goal is missing some valuable information.
Okay, here's a goal. By 2 weeks, instruct in medication management.
Linda, that is not even a goal. That is an intervention.
I guess you're right. I might have to stop using that goal.
How about this goal? In 2 weeks, the patient will use thickened liquids and will use the chin tuck as a compensatory technique to demonstrate a safe swallow.
This seems like a well-written goal. A speech therapist might be even to make the goal more specific if he or she works with the patient and determines which thickened liquids would be most effective. It's important to know that our goals can be modified and changed during the course of treatment as the patient's status changes.
Okay. Thanks very much, Nancy. Now, it is important that a global transdisciplinary goal, here noted as the disability goal, is established. This goal will serve as a measure of the patient's success through the help of our interventions. These are the goals best suited to the 485 form. Now, to build the components of the disability goal, our various disciplines will each establish with the patient some discipline-specific long and short-term functional goals. We will use the case of Leroy to create and demonstrate some of these goals.
At this time, we recommend that our viewing audience, as individuals or in small groups, take 3 to 10 minutes to complete the task of generating a few discipline-specific goals for our patient Leroy. Use the elements of SMART goals to create your goals for Leroy. Don't forget to reference your assessment and evaluation information from each discipline and from the OASIS to establish these goals for Leroy. Once your goals are written, take an additional 5 minutes to share these goals with the rest of your viewing audience. Together, determine whether or not the goals meet the SMART criteria, and if not, help to formulate the goal in a way that is SMART. You may pause the DVD while you write and share your goals.
To supplement the goals that you have created, our Rehab Council put together some goals of our own for Leroy, which we will now share. Now, these are the transdisciplinary goals for the 485. Our first goal, the patient will return to his prior level of community mobility, including getting out to meet friends for coffee, within 3 weeks. He will return to independence with home mobility and self-cares within 3 weeks. And he and his spouse will return to living independently in their home without assistance from family in 3 weeks.
Here are some discipline-specific goals for nursing for Leroy. The patient or caregiver will verbalize, demonstrate Coumadin management without errors and INR within the ordered range as specified by the physician. The patient will have managed pain to a level equal to or below 3 of 10 on the numeric pain intensity scale by the appropriate use of pain relief measures to maximize functional mobility by 3 weeks. And the patient will verbalize, demonstrate knowledge of surgical incision management, normal healing and signs and symptoms of complications without verbal cues by 1 week.
Here are some OT goals. In 1 week, the patient will demonstrate ability to utilize energy conservation and recovery breathing techniques during dressing and bathing tasks with 2 or fewer verbal cues. In 2 weeks, he will complete lower body dressing independently, sitting at the edge of the bed using a reacher, dressing stick, and sock aid. In 3 weeks, he will complete 3 showers in his basement, showering safely with 2 or fewer cues needed to utilize adaptive equipment and fall prevention techniques.
And here are some PT goals. The patient will increase left quad strength from 3 out of 5 to 4 out of 5 to allow independent transfer in and out of bed, as well as to various seats within the home without a device, and this is where it'll be up to you and patient specific, in 1 to 3 weeks, depending on the patient. The patient will increase left plantar flexor strength from 3 out of 5 to 4 out of 5 to enhance gait efficiency and provide necessary strength at the ankle joint to be able to ambulate 450 feet on outdoor surfaces to access the mailbox using a straight end cane in 3 weeks. And the patient will increase active left knee flexion from 87 degrees to 115 degrees and active left knee extension from 12 degrees to 0 degrees to allow safe negotiation of 1 full flight of stairs using reciprocal pattern, 1 railing, and the assistive device to access shower and outdoors safely in 3 weeks. And we could specify single end cane if we wanted to for assistive device.
Now, there is no cookbook for writing a care plan. You have to get your patients up and moving to really perform an accurate OASIS assessment. We need to collaborate as a team with the patient and caregivers in order to gather complete information and to establish meaningful and effective care plan interventions and goals.
We need to perceive a common patient goal or 2 or 3, regardless of our discipline. And we need to create SMART goals, which will help documenting our therapy reassessments as well as our discharge summaries. We risk payment denial and poor outcomes for our patients when we do not create good care plans. As we continue to adapt to our ever-changing healthcare environment, the one thing that we can keep as our constant is our expectation that our documentation must reflect the skill that each of us provides and the medical necessity of each of our visits, all disciplines. Solid goal writing will help us facilitate this.
On our last slide, we have included some of the resources that we used in creating this presentation. If you have questions to ask of our Rehab Council, you may direct them to us via the MHCA, Minnesota Home Care Association, website included at the end of our resource list.
Thank you for your passion in continuing to develop your skills so that you can best help your patients.